Welcome everyone to today's program. I'm Heather Punke with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following the completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they don't have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time, but that email will not include the presentation. It is now my pleasure to introduce today's presenters. Alicia Torrance is the Senior Vice President of Clinical Operations for Surgical Directions. She has over 33 years of experience in perioperative clinical, medical surgical, and critical care nursing, as well as nursing leadership in both profit and nonprofit health systems. As former SVP of Clinical and Marketing Services at a major medical device manufacturer, she was responsible for providing clinical direction, program development, clinical consultation, and clinical quality review for perioperative services in hospitals and surgery centers, as well as education and training of perioperative clinicians. Alicia was clinical editor for the OR Connection magazine, Infection Prevention Now, and managing editor for Healthy Skin magazine. Her work has been published in numerous publications, and she speaks regularly in various healthcare arenas. Next, we have Dr. Joseph Bosco, who is Vice Chairman for Clinical Affairs of the NYU HJD Department of Orthopedic Surgery and Clinical Associate Professor of Orthopedic Surgery at New York University Medical Center. He was the Associate Director for the New York University Hospital for Joint Diseases Orthopedic Residency Program from 2000 to 2005 and served as Chief of Orthopedic Surgery at Jamaica Hospital Medical Center from 1998 to 2006. Dr. Bosco has served as team physician for the Durham Bulls and Brooklyn Cyclones minor league baseball teams. From 2002 until 2004, he was a team physician for the New York Mets professional baseball team, and he currently serves as team physician for several area high schools. In 1998, he joined the orthopedics department at New York University, where he remains today. He has published extensively and lectured, both nationally and internationally, on a variety of sports medicine subjects, as well as quality and patient safety. It is now my pleasure to turn the floor over to Alicia to begin today's presentation.
Hello, either good morning or good afternoon, depending on what time zone you're in. I'm going to tell you just a little bit about Surgical Directions, who we are, what we do, and then it'll be my pleasure to turn it over to Dr. Bosco to really talk about their journey at HJD in the orthopedic department. Surgical Directions is the nation's leading partner with hospitals, surgeons, anesthesiologists, and perioperative nurses to help transform perioperative and anesthesia services. We've been fortunate enough to work in over 540 hospitals all across the country of various size and complexity, and our results are proven to be sustainable and substantial over a period of time long after we're gone. We were very fortunate to work with NYU Langone Medical Center when they began their journey with bundled payments in the orthopedic department, and to assist them to develop a very impressive value proposition. Next slide, please. Next slide. Healthcare leaders' role today is to improve the value of perioperative services, and the only way you can do that is by improving the quality and reducing the cost to obtain that value proposition. And it is very important that you do not allow the cost constraints to affect your quality outcomes, and that was one of the things that NYU was so impressive in how they went about this. Next slide. One of the most successful strategies that we've used in transforming perioperative services is to put in place a governance structure that's called the Surgical Services Executive Committee. And this group works like a board of directors to work together, bringing surgeons, anesthesiologists, nursing, and senior leadership, and to govern and work with performance improvement teams to put in new strategies and make change. Because as you know, change is one of the most important things that hospitals have to do today to be successful, but it's also very, very hard to put in place and to sustain that. So Dr. Bosco became the Surgeon Medical Director at NYU Hospital for Joint Diseases while we were there partnering with them in creating this governance body and establishing the performance improvement teams to not only transform perioperative services, but to launch their bundled payment initiative. Next slide. So with that, I want to turn this over to Dr. Bosco to talk about the journey that NYU went on for bundled payment. And then as a bonus, he's going to also talk to you about the comprehensive care for joint replacement, which CMS is scheduled to launch January 1st, 2016. So with that, Dr. Bosco, please take it from here.
Thanks, Alicia. Thank you for those kind remarks. So Alicia's exactly right. You know, we a little bit about NYU. We have the Hospital for Joint Disease is a single specialty orthopedic hospital that's part of NYU, and this year we ranked number 5 in U.S. News and World Report for orthopedic care. We do 20,000 orthopedic surgeries a year, of which 5,000 are joint replacements. So we have a very busy orthopedic center, and you know, we are in the past we've done very well with the traditional fee-for-service payment method, but we saw the future, you know, was going to hold bundled payment and payment based on value rather than just volume. So in spite of doing so well in the traditional way, we decided that we would embark on looking at bundled payment and alternative payment strategies. And that's what we first came to Bundled Payment for Care initiative. Next slide, please. So just as an overview, when you're looking to re-engineer how your hospital provides services, I mean, it's very difficult to do that without some outside help, you know, to give fresh ideas, to give a template. And that's where a team like Surgical Directions was integral in helping our hospital, you know, understand and achieve its goals of being re-engineering the perioperative services so that we could provide service in a value-based environment and be successful at the Bundled Payment for Care initiative. So just to overview, the BPCI is a voluntary program put out by the government, federal government. It has over 50 different bundles, of which 15 or 16 are orthopedics. And we chose to participate in 3 different orthopedic bundles: the spine surgery and total knee and total hip bundles. And there's inside those, there's different bundles for different procedures, but there's different ways to bundle the care. And I'm not going to bore you with the 4 different ways, but we chose the second way, which is basically 72 hours before the patient enters the hospital, their inpatient hospital stay, and 90 days after they leave. So that was the Type 2 bundle that we chose to participate in. Next. And so to participate in that bundle, basically what Medicare does, it's Model 2, they calculate how much your spend was for the 2 years preceding going into that bundle, and that's your target spend. And they take 2% off the top of that, and any savings you achieve greater than the 2% off of your traditional spend in that care, you get to keep, and you get to redistribute to your physicians and gain share. And so we thought that this was very attractive to us. It really forces you to re-engineer your processes and look at your costs and make sure that every intervention you give to the patient adds value to the patient. Okay, next slide. And so why the government and other payers are so interested in this is it takes a disjointed, the American way of doing care, which is different patients giving care, a lot of different providers. Many times they don't communicate with each other. So it takes this disparate, uncommunicating way of giving a patient care and converts it to one team, one vision, 90-day episodic care where everyone's communicating and everyone's providing care in a linear type fashion. Next slide. So as I said, we chose 2 DRGs with the major joint replacement with comorbidities and without comorbidities. And you can see that in DRG 469 and 470, the payments very different, because with comorbidities it adds a lot of payment to your bundle, because there's a lot more services that are required for these sicker people. Next slide, please. So the target price, as I said, but this is a nice schematic. You get any services within 72 hours prior to admission. That includes PAT, physician visits, ED visits, any services during the acute hospital stay, such as the surgeon's fees, anesthesiologist fees, consulting. So if your hospital is used to having pain management consult and 5 different consultants for every patient, then that comes out of the bundled payment, so you don't get paid any extra for that. And also, and more importantly, it includes any services provided during a 90-day post-acute period, such as inpatient rehab, which is the bundle buster, skilled nursing facilities. Again, if you send your total joints, I'm getting a little ahead of myself, but if you send your total joint patients to inpatient rehab or skilled nursing, there's no way you could be successful in the bundle. You can't eliminate it totally, but we went from 80% going to only 20% going. That's what really was successful for us. To outpatient therapy services, readmissions, all your readmissions get charged to you, and not only the readmissions that occur at your hospital, the readmissions that occur at other hospitals, and readmissions for all causes almost. Medications, physician visits, DME, lab services, everything is included in that bundle. So you have to examine all the services you provide these patients to make sure that these services add value. Next slide. So I'm just going to talk about now a little bit about the clinical pathways and workflow strategies. And again, this is where a consultant and a company such as Surgical Directions can give oversight and help a hospital rethink its clinical pathways and workflow strategies so it can be successful in a bundled care payment environment. Next slide. So important is a clinical management pathway, and these patients need to be managed not just by the physician, by the attending, but by a clinical care coordinator, we call them. And this clinical care coordinator, they're PAs and nurse practitioners that we hired. Once a patient is scheduled for surgery, they contact the patient immediately and start setting goals and letting patients know exactly what they have in store. They get told they're going to go home after post-op day number 2 or 3, and that they're going home, not to inpatient rehab. And for instance, a lot of patients will say, I can't go home because I don't have a bathroom downstairs, or I can't go home because I don't have, it's hard for me to get up and down the stairs. So our clinical care coordinators will actually work with the patient to get them the appropriate commitment, the equipment, and everything to allay their fears, so they understand that they can go home and that they will be getting therapy at home. So again, everyone that sees that patient, all care providers that see that patient, whether they're the doctor, anesthesiologist, people that clean their rooms, will tell them the same thing. You're going home after 2 or 3 days. You're going home. You're not going to a rehab place. So they get the same message. And the clinical care coordinator also is very helpful in the post-acute care. They'll call the patient. They'll make sure that there's good communication between the patient. They'll understand there's issues, that the patient will come back to see the doctor, not to go to the normal the emergency room. We had to work with all our providers or physicians, because the standard, you call a physician's office and they're not home, or it's past 5 o'clock, and what do you get? You get, if there's an emergency or a problem, go to a local emergency room. That's not what you want in a bundled care. You want that patient to communicate with the doctor and either come back to the hospital or have some other way of, maybe through telemedicine, going and seeing their provider. Once you send that patient, once a patient goes to a local emergency room, you lose control of the care of that patient. And more importantly, you lose control of the cost of the care of that patient. So again, this is a fundamental rethink, a re-engineering how we take care of patients. Next slide. So the goal, of course, nothing's ever 100%, so you can't get 100% of patients doing the same thing. But we developed pathways that were good for 90% of the patients with exclusions. But the exclusions were determined by the pathway criteria and not physician preferences. So the physician, you got to get physician buy-in. And again, this is where a group like Surgical Directions that comes in, they don't have axe to grind. They haven't been competitors, different physician groups, competitors to each other. They come in and give a reasoned approach to clinical care pathways, and it's much easier for them to help the hospital develop its own pathways with external help. Next. Next slide, please. So it starts in the pre-hospital workflow. Again, PAT, medical clearance optimization, assisted by surgical directions, re-engineering the PAT. Not all the patients physically have to come, but you need to get the evaluation and testing 4 weeks prior, because as we said, all care within 72 hours of admission are included in admission. So if they need to get a cardiac cath or any kind of cardiology tests or any kind of other tests, it's good to make sure they get them before 72 hours. Make sure this stuff is done ahead of time. We look at everything. We usually don't get urinalysis anymore. We try and make sure patients are maximizing with concerns to their blood glucose, and really minimize the amount of preoperative testing, so that it's appropriate for the patient. We're not doing too many tests that would just run up the cost without really providing any value to the patient. Next slide. Okay, so now the inpatient workflow. We've gone from preoperative now to inpatient. Standard order sets, and again, order sets, and we're on Epic, but order sets are good and they can be bad, because a lot of times order sets promulgate tests that really shouldn't be done. So you got to look at your order sets. If you're a hospital that uses order sets, you got to look at them and make sure that everything on an order set adds value to the patient. For instance, we looked at a lot of for total knee replacements. That if you do a total knee replacement under tourniquet, do you really need to get a hematocrit when they hit when they hit the recovery room? If it's done under tourniquet, no, we probably don't. Do you need to get a creatinine when they come in to the recovery room? No, because we looked at 16,000 consecutive creatinines, and less than 0.2% were abnormal. Of the 2.2% that are abnormal, nothing was done. So why get a creatinine? Why get these lab tests? Because not only the lab tests cost money, but the workup they generate costs money. So you want to do everything that adds value without, as Alicia said, when you try and cut costs, you can, if you look at what Michael Porter talks about, value is outcomes divided by cost. So theoretically, if you cut costs by 30% and decrease outcomes by 10%, you're adding value, but none of your cost cutting can actually affect detrimentally your outcomes. So you can cut costs, but they cannot make the outcomes any worse. So, everything you do, you got to make sure it's safe for the patient. Next. So now post-acute care workflow. Again, as I mentioned before, when you send these patients to inpatient rehab, that's a bundle buster, we call them, because the average cost for inpatient rehab runs about $15,000 to $18,000. The way that works is these rehab places get a per diem fee of $500 about, depending on what kind of Medicare they have, and it's usually up to 21 days. So theoretically, it's amazing how each one of those patients stays every bit of the 21 days, even though they can go home sooner. Because if you're running a nursing home or a SNF, then of course you're going to keep the patient as long as you can and maximize the amount of money you make off of them. So sending a patient home with therapy costs about $1,000. So our goal is to get every patient home. Now we can't get every patient home, but if you're 85 to 90% of patients home, you're going to do well. Okay, next. Next slide. So the Episodes of Care initiative, we wanted to reduce readmissions, reduce length of stay, reduce implant and supply and drug costs, reduce OR time, alter discharge patterns for more cost-efficient settings, aka don't send them to rehab, look at utilization, unnecessary consults. Again, the old-fashioned way of doing it was patient would come in a hospital, they get everyone with consult on them, and everyone would send the bill, which was fine, but that drove up the cost of medicine. And when you're in a bundled care environment, you get one price whether you have 5 consults or 1 consult. And so we sent benchmarking goals and looking at our episodes as well. And I will tell you that, if you're a hospital that thinks they know their readmission rate, when you enter one of these bundled care payments with the government, you'd be surprised at your readmission rate, because every readmission that occurs inside the United States gets counted. So you think you may have a good handle like we thought, but our readmission rate at 90 days was twice as high as we thought, because patients get readmitted all over the country and all over the area that you don't know about it. They may get readmitted 2 months after surgery for a gallbladder attack, but still that counts, and still you have to know about it. So don't be surprised when you're in these bundled payments that your readmissions are a lot higher than you thought. Next. All right. So this is our results after the first year. We had 721 Medicare patients which were eligible. The average length of stay was decreased from 3.5 to was decreased from 3.5 from 4. Now our length of stay is under 3 days. So our inpatient discharge inpatient faculty decreased from 63 to 44%, and now we're down to about 20%. Readmissions, again, 80 out of 721 patients, 7% at 30 days, 13 at 90 days, and these are all-cause readmissions. If a patient has an MI, 89 days after their discharge from the hospital, that counts. One of our patients, was in a car accident 2 months after her surgery, that counts. So, but our readmission rate has decreased now. It's about half that because we're really monitoring our patients a little closer. And plus, and we'll talk about this later, we're maximizing our patients prior to having their surgery. So their medical problems are more under control, so they're not as sick as afterwards. And so we were very successful during the first year in terms of cost savings. And our hospital cost per case decreased about $7,000, which was significant. It helps when you're really expensive before you go in too. So, but we were expensive, but now we're less expensive. Next slide. And so we looked at the DRG 470, which was total joint without major comorbidity, and we had a 17% savings during the first and second quarter. And for DRG 469 with major comorbidity, we're about 8% savings. So again, it was very successful, but it takes a unified effort by all stakeholders at the hospital to have this done. And the reconciliations where you get paid occur 6 months after the last 90-day episode. So it still worked pretty well. And we gained, next slide, please. We Gainshared with our surgeons too. So I will tell you that if you're going to participate in this, all the surgeons that do these cases at your hospital have to participate. But you can get up to 50% over Medicare if you do well. The hospital does well, and our hospital did well, so our surgeons were making more money. So the idea is if you're a surgeon, you're going to be enrolled in Medicare and accept it, you might as well be enrolled in a bundle because you can do, your patients get better care and you're rewarded for it financially. So we had a decreased length of stay, decreased discharge to inpatient facilities, and decreased cost of the episode of care, and that's really what was most important. Next. And so, and I touch on this briefly, but risk factor modification was very important. And next slide. What I mean by that is that, your hospital may have a 1% infection rate after a total hip replacement or total knee replacement, but that doesn't mean that every patient has a 1% risk. We looked at our patients and found that if you're diabetic, if you're obese, and if you smoke, and you have a positive nasal culture for staph, your infection rate's about 15%. The reason why I talked about those 4 things is all 4 of those, smoking, uncontrolled diabetes, obesity, and the nasal carriage of staph, are all modifiable risks. You can enter the patients in a smoking cessation program. You can get them motivated to lose weight. You can decolonize their nose. You can send them to diabetic management. All these things will decrease the risk of developing a complication before surgery. And you may say, well, can you not operate on certain of these patients? Yeah, ethically, you don't have to operate on every patient that comes to your door. But more importantly, if you do a shared decision-making model where you talk to the patient and say, listen, our overall infection rate is 1%, but because you have these risk factors, your infection rate is 15%. That may rethink their willingness to have surgery, especially if you say, well, it's 15%, but if you go into smoking cessation, stop smoking, lose weight, get your diabetes under control just temporarily, it'll go from 15% to 2% or 3%. Well, a lot of patients are willing to do that. So what we found is that by understanding their patient's risk beforehand and getting them to modify them, that we can decrease our complication rate and decrease the cost of our care. Next. So again, these are our comorbidities. We're like every other place. We had most of our patients have comorbidities. That's just the way it is. Hypertension, hyperlipidemia, tobacco use, diabetes. So I don't have to read the whole list, but I'm sure your hospitals are the same. Next slide. So we developed a perioperative orthopedic surgical home, or POSH, after one of the Spice Girls. One of Dr. Iora is a big Spice Girl fan. So, but that's what we did. It allows us to risk stratify these patients. Next. So again, we have a hard, some certain hard stops. If they have nasal colonization, there's a hard stop. We make them do nasal screening, decolonization. We give weight-based vancomycin when necessary. We use iodine and chlorhexidine wipes in the perioperative period. We do thrombogenic screening for high-risk patients for blood clots, VTEs, because we know that if a patient is not at a high risk for developing VTE, and we can put them on aspirin and foot pumps, their risk of developing a bleed after surgery and wound complication and infection is much less. But these patients have to be risk stratified. Smoking cessation, again, if they're a smoker, we won't allow them to be scheduled unless they go through or listen to an anti-smoking pitch. Cardiovascular optimization and stroke prevention, again, we make sure the patients are on ACE inhibitors and statins. Weight control, it's hard to get people to lose weight, but we at least counsel them on weight control for patients with BMI over 40. It's not that we don't do patients with BMIs over 40, but we counsel them about weight loss. If they try and they can't do it, well, then we'll do them surgery at some point. We try and avoid the catastrophizers, the patients that we know that, magnify their symptoms, because joint replacements are done for pain, and certain patients are symptom magnifiers, and they have hysterical components, and we're not trying to proselytize these patients or be subjective about things, but we know that certain one of these patients that have a lot of anxiety don't tend to do well, so we may have them see a psychiatrist or psychologist before. If they're known to be drug and alcohol abusers, we'll have that taken care of as much as we can ahead of time. Again, not all patients, but as many as we can. And full education program, diabetes control, all stuff that we do. Next slide. And so just, again, I'm just going to touch on this briefly. This is total joints are elective procedures. So a hospital and a physician is well within its ethical right to tell a patient, we're not going to do your surgery because you're too high of a risk. This is not a patient this is not a non-elective procedure. And, because if you look, patients, there's a concept of the autonomy of a patient, that the autonomous patient should be able to make medical decisions on their own and do what and act. It's an economic principle. They should be able to act as in their own interests and do what's best for them, what they think is best for them. But sometimes what's best for them may not be what's best for your hospital or society. And if they decide they want to go ahead with this elective surgery, despite all these risk factors, and want to act as a free agent, then that can cause a problem with the hospital and cause scarce resources to be used up. And theoretically, if you operate on a lot of sick patients that have a lot of complications, and that may preclude you from giving care to some patients that are not as sick because basically the hospital runs out of money, or your risk factors are too high, or your complication rate's too high. We see that in Canada and some other places where, the hospital has a budget. In Maryland, hospitals have budgets. And if you take care of 3 patients that have a lot of complications, that may exhaust the hospital's budget for knee replacement for the rest of the year, and you may be denying other patients knee replacements. So again, you're ethically within your moral bounds by acting what's good for the patient, what's good for society, by denying or delaying surgery on these patients. You don't have to do the surgery. Now, no hospital, or physician wants to deny patient surgery, but you can certainly delay it and have them do some risk stratification, risk modifying things. Next. Yeah, we went through that. We'll go to the next slide. And, again, in all these risk stratification pathways, that it's very difficult for a hospital itself to do without any kind of outside help. And again, that's why we found it was worthwhile for us to engage a group like Surgical Directions to help us establish these pathways, to help us, show what other people have done, so we're not reinventing the wheel. Because it's very difficult to do this all internally. So it helps with a little external help. Preventing readmissions, the role of the internist, again, and we've written a bunch of articles, a couple articles on this, but orthopedic readmissions are a little different than medical readmissions. When you look at readmissions for pneumonia or stroke or heart failure, those readmissions occur because it's a continuation of the disease process. You have a person with heart failure, you admit them to the hospital, you diurese them, you put them on medications, and they go home, and guess what? You haven't cured them of heart failure, but they stop taking their medications, they don't do it like they're supposed to, or their heart failure comes back again, they get readmitted. So a lot of that has to do with communication. But for orthopedics, most of our readmissions occur because of surgical complications. So it's not that we haven't eradicated their arthritis. We have, but they get readmitted because of a complication that occurs as a result of surgery. That's what 60% of our readmissions were. So the idea to reduce readmissions for us is reducing complications such as bleeding, such as VTEs, such as infections. Again, so that's what we do. If you want to reduce readmissions for orthopedic patients, reduce the complications they have after surgery. Next slide. So and it helps if you can identify which patients before the surgery at increased risk for a readmission or complications. And that's why we develop a readmission score, and it has to do with more morbidities, and we have a pretty good idea that we can, by just doing a routine history and physical, we can identify patients that are high risk for readmission. And what we do with those patients that are high risk for readmission is we can counsel them, and also we can direct resources towards them to decrease that risk, and we've been very successful with this. Next slide. So you see our average length of stay has gone down, and now it's way less than 3. And these are Medicare patients. So Medicare patients always have a higher length of stay than non-Medicare patients. And we're less than 3 days now, and our readmission rate's gone down too. And just I'm going to just take a brief digression about length of stay. Length of stay is probably the worst indicator for quality. People like to measure it because it's easily measurable, but we found, just economically speaking, that if you send the patient home at day number 3, if you send the patient to a rehab place at day number 3, that's not so good. If instead of sending them to a rehab place day number 3, if you keep them for 5 or 6 days in the hospital, but instead of sending them rehab, you send them home, that's a huge money saver, and it's best for the patient. So we will, if we have to, we'll keep our patients for an extra 1 or 2 days or 3 days so they can go home rather than go into a rehab place. And what we found is that the cost of a hospitalization isn't spread uniformly over every day of the hospitalization. When you're doing a total joint replacement, 80 to 90% of the cost of that hospitalization occurred during the first day and a half. OR costs, implant costs, all these things. So from day 4 to day 5, if there's no complications and they're just waiting till they can go home rather than a rehab place, the variable cost of the hospital is very low. It's the cost of a meal and maybe some physical therapy sessions. Now, that's assuming that they're not taking out a bed that could be used by another patient. But most hospitals have excess capacity these days. So we did a lot of economic modeling and actually published a paper and found that you have 5 or 6 days of additional length of stay that you can keep them in the hospital rather than sending them to rehab, and you'll still do better financially. Because, again, the cost of keeping them in the hospital from day number 3 to day number 6 is probably $200 or $300 a day, and you control those costs. Whether in rehab where it's $500 a day, and that's for 21 days where you don't have any control. So again, if you have to, keep them a few days and send them home rather than at day 3 send them to rehab. Next. And of course, you can't correct or understand what you don't measure. So the idea of making dashboards and scorecards is very important. And this is what our bundled payment initiative scorecard looks like. This is our discharge and average length of stay. Okay, and this is our observe over to expected is the one on the top right. And we have readmission rates. Discharge disposition, again, is very important. You see that the yellow is discharged to home, and the purple and the red are discharged to inpatient places. And in a couple of slides, you'll see that of all the patients that exceed the average bundled price, 95% of them are because they've gone to inpatient rehab. So again, that's very important. And what we found as well, and we published this in several articles, is that we thought initially, just like you know, people thought that the world was flat and everything, the stars revolved around the earth, is that if you sent the patient home rather than a rehab place, the length of stay would go up and the readmission rates would go up, because it would take longer to send them to send them home rather than rehab. And if they were home, they'd end up bouncing back. But of course, we know now, after we looked at our data, and other people have reported the same thing, is actually the readmission rate from a SNF or inpatient is higher. Why is that? Because they get sent to local emergency rooms when any wound looks red and it's not in your control. And plus, in a rehab place or an inpatient facility, they're exposed to different bacteria and different organisms, so the infection rate's higher, the readmission rate is higher. Additionally, you know, not only is the readmission rate and infection rate is higher, but it costs more. So by sending them home, and the length of stay is not affected, or even longer, because what happens is on a Friday, when you want to send them to a rehab place, when the rehab people look at them, you don't hear back for 2 or 3 days until they're ready to accept them. So we found that our length of stay didn't go up, it actually decreased when we started sending patients home, and the readmission rate decreased because it's safer. And so these are one of these things that when you're looking at the value proposition, outcomes divided by cost, you're decreasing the cost with this intervention, sending them home, and you're improving the outcomes. So this works on both sides of the value proposition, improving outcomes while decreasing costs. So that's a winner for everyone. Next slide. Okay, so now, and I'll be brief about this. About a month ago on a Friday at about 4 o'clock during the summer, when the rest of us were enjoying our vacations, the federal government came out with this bombshell called the Comprehensive Care for Joint Replacement, CCJR. Next slide. And basically that was an extension of the voluntary BPCI, what we did voluntarily. Now they're going to make a third of all hospitals do this by starting the 1st of 2016, right? 25% of all hospitals, right? 25%. And they're making them go into the bundled care for total joints. There are some differences, but nuanced differences. But it's basically taking this voluntarily program and now making it non-volunteer. And most of us that deal with the government and are familiar with this really don't think that it's going to start the 1st of 2016, but it's going to start at some point. So back, you know, before they dropped this on us, we knew somewhere that these alternative bundled care payment arrangements were going to be increased over time and be more prevalent, but we were unaware that it was going to be this precipitous. Next slide. So, you know, they're looking at saving $153 million over 5 years. Not that much in the grand scheme of things, but it's a way to re-engineer how hospitals think. And they're going to start with total joint bundles, but they're looking to do bundles for cancer care, valves, and other things. So, next slide, please. And this is basically the government's smart because they're taking the most expensive hospitals and making sure they get in the bundles first. And the least expensive ones, they're dividing the expense in quartiles and making sure that 33% of the most expensive hospitals are in the bundle, and only 20% of the least expensive hospitals. So they're really, you know, they put a lot of time and effort into this. Next slide. But Gainsharing is allowed, and they'll allow Gainsharing physicians. Any provider can be Gainshared. But during the first couple of years, during the first year all hospitals participate, there's only upside potential. If you lose money or you end up being more expensive, there's no penalty during the first year. But there is if you do save money, you do get to keep it, or 50% of it. Next. And again, this is these are various episode durations and costs for 30-day, 60-day, and 90-day. And this is the average throughout the country. Next slide. All right. So again, this is going to come. It's going to be here. Whether it starts the 1st of 2016 or it's delayed 6 months or 12 months, it doesn't make any difference. And the other thing is, just like a bundled care payment, the voluntary program, if your hospital saves costs, but achieves cost saving, but the quality is not doesn't meet a certain threshold, then you won't get any of that money back. And the threshold is about 30% percentile in terms of readmissions and infection rate. So if your hospital is not at the 30th, higher than the 30th percentile for infections and readmission rates, then you're not going to get any money back. So there is a certain quality threshold you need to exceed in order to get reimbursed your savings. Next. And it's interesting too that they're next slide. This is not that helpful. So the way they're doing it is that initially you will get compared to, during the first 2 years of a 5-year, the CCJR, your hospital will get compared to itself. So if you make cost savings, if you're an expensive hospital, it was inefficient, and you do better, you'll get some money. If you're a very efficient hospital, in the first 2 years, it's hard to do better, so you may not get that much money back. However, during the 3rd, 4th, and 5th year, this is going to transition, and it's going to be regional. So now you'll be compared to your peers. So if you're a poor performing hospital that's improved, but by year 3 you're not quite where your peers are, you're going to be penalized. And if you're a hospital that did well initially, that's a high performing hospital, that's a high efficient hospital, you may not get a lot of money back your first few years, but years 3, 4, and 5, when you're compared against your peers, you'll get more money back. And it was a good way to draw the hospitals in. Next. And again, you get, if your hospital participates in patient measures, patient outcome measures, and can provide patient-derived outcome measures, or PRO, then instead of 2%, instead of the Medicare taking 2% off the top of your savings, they're going to take 1.7%. So it's important for hospitals to establish a patient-reported outcomes mechanism. Again, this is something where surgical directions can help with, because it's very difficult to do this on your own. Next. And we'll finish up right now. So again, this is probably going to happen. They looked at the BCPI, the BPCI, the stuff that was voluntary, and they thought that this could be applied to all hospitals. Next slide. And once again, there'll be certain, as I mentioned before, there'll be certain quality thresholds that you'll have to reach, and these are hospital level 30-day all risk standardized readmission rates, complication rates, and HCAP scores. So if you don't do well on your HCAP scores, then no matter how much money you save, you won't get any of it back. Next. All right, we can skip this as well. We talked about this a little bit. Okay, and just go to the last slide if you could. So I'll sum it up by saying that the CCJR is coming at some point. Whether it's the 1st of this year or the 1st of 2007, doesn't make any difference. It's going to come, and hospitals have to prepare for it, because, you know, and it's only a matter of time till the commercial insurers start doing the same thing. And in order to re-engineer hospital processes and turn your hospital from a fee-for-service arrangement where, you know, costs really weren't maintained, or there was not only a great cost accounting, because the more you charge, the more money you made, to re-engineering that process to now a value-based process where, you know, everything's done with the eye towards value. All the processes are engineered. Everything's on a pathway. It takes a lot of external support, and it's very difficult for a hospital, even big hospitals, with our resources, to do this on their own. And I really think that a group like Surgical Directions or any consultant of that ilk comes in, and they can work with the hospital. They're not going to show you what to do, but they'll give you the tools to make your own resources and have you own your own pathways and total joint initiatives to make this successful, to re-engineer your hospital from a fee-for-service, volume-based to a quality-based. Thanks. And we'll take questions now.
All right, great. Thank you so much, Dr. Bosco and Alicia, for that informative and enjoyable presentation. As you mentioned, we will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. If our presenters do not get to your question, they will follow up after the presentation. To start, Dr. Bosco, you could probably address this. How would you recommend an organization begin when engaging in a bundled payment program?
That's a great question. You know, so basically, you need to have, in order to engage in this bundled care payment program, you need to have all stakeholders involved, and that's from providers, hospital administration. So everyone has to be aligned. Everyone has to be willing to do this, because if the physicians are not aligned and the hospital doesn't want to put the resources into making this happen, it's not going to work. So you need both camps. And so the physicians have to be incentivized through Gainsharing, and the hospital has to be willing to hire clinical care coordinators, to hire consultants, to look at their pathways to make sure everything's okay. So we'll take an investment on a hospital part too. But you have to get everyone aligned. All the stakeholders have to understand that this is important. If they all sign on to it, then that's the first step. The next step is you have to look at your present situation. You have to be able to measure things through dashboards, outcomes. You have to get an idea of your readmissions, your idea of your length of stay, the idea of the cost of providing care, which a lot of hospitals don't know. And so all this has to be understood before embarking on some risk-sharing agreement like a bundled care. So that's the first couple steps.
Great, thank you. We have another question from the audience. What is the role of implant suppliers in partnering with providers to control costs in CCJR? Many are offering value-add programs. Are these effective?
So I'll take that too. So traditionally, physicians have been aligned with implant suppliers, whether it be expensive trips, whether it be consulting agreements, whether it be intellectual property. But over the past 5 years, this has changed because the Sunshine Act has really decreased the amount of payments to physicians for incidentals, and more physicians are going into an employed mode for the hospital, so they're aligned with the hospital. So the implant manufacturers, they don't have a lot of incentive to cut costs. Basically what you need to do, again, physician alignment. You need to, the hospital has to be in control of the cost of their implants. They have to negotiate implant prices. First of all, they have to know what implants are used and how much it costs. That's a big step for a lot of hospitals. Then they have to look at variability. And then they have to have pathways to say that, okay, based on the patient's activity level, they're going to use such and such type of implant, and you have to have reference pricing. And reference pricing means you set a price for the type of implant, and any manufacturer that wants to supply the implant has to meet that price. If not, they don't. And what happens is the manufacturers, the companies that have the greatest market share, are usually not willing to meet the price, because why would they want to cut their prices? So you get the companies with the smallest amount of market share to meet the price. Well, that requires a physician to be aligned with the hospital. Say, listen, if you don't meet my price, I'm going to use this other company. And they may have to use them for a couple of weeks. And usually the companies get the message and they will meet the price, but it takes alignment. So I don't think that implant companies are really your partners with this. Really, it's almost like a zero-sum game. The more money they make, the less money you make, frankly. So, I don't mean to be dour about that, and I understand. I don't have a vendetta against implant companies, but a lot of times they will discount their implants by giving you less service too. So they've gone to rep light, so you don't get representatives with every case, but you got to worry about that. So you have to control the price of the implants. You have to set reference pricing, and you have to set limits to what type of implants can be used for what type of patient. Demand matching. Hope that answered your question.
Great, thank you for that insight. I have another question from the audience. Is NYU Langone going to expand this process across other clinical DRGs? If so, what areas would fit well with this model, and what areas might be more difficult to deploy bundled payments to?
Okay, that's a great question. And I will tell you that we initially went into 4 bundles: total knees, total hips, valves, cardiac valves, and spine, lumbar spine fusions. And valves and total joints were very successful. Lumbar spine fusions were a failure. So you think that a hospital that's theoretically aligned enough to do well with implants, with total joints and valves, can be well aligned enough to succeed at everything. But what we found is that when you look at the spine procedures are very heterogeneous. And what we found, the reason why we were unsuccessful with this is because the care of spine has evolved over the past 5 years. In that we looked at there's more levels being fused and more revisions being done. So if you compare your cost to the a couple of years before, these costs were lower. Now our costs are higher because we're fusing more levels and doing more revisions. So it's basically changed how it's evolved, and we're treating people differently for spine than we treated before. And plus, there's a big difference between a single level fusion and a front back multi-level fusion. And CMS refused to change these or consider this. So that's what we call a flawed bundle, that no matter how efficient your hospital is, no matter how much cost control you have, you can't be successful at that. So that was a good lesson for us as well. So the next thing we're looking to expand it to is revision total joints, because we think we could do well with that too, because we could control the implant costs a little better. So that's the next thing we're looking to expand to.
Great. Thank you, Dr. Bosco. I have another question from the audience. How do
Sure.
you handle paying each provider, and how do you deal with deductibles when various providers are involved?
Well, for Medicare, there's no deductible, right? Medicare is straight Medicare, and every 6 months there's a reconciliation. And as long as that provider meets the quality threshold, infection rates, readmission rates, which 80% of our providers did, then they get, based on how many cases they did, a share of the savings. So if the savings was, let's just say $100, and you did 10% of the cases, you get $10. But it averaged to about 130%, 30% more over Medicare. Which again, if a provider is going to be in Medicare, they might as well be in this program, because their care improves and their reimbursement can improve. So there's no reason not to.
All right, thank you. Another question here. Does your governance team include a member of the legal department as it relates to the Gainsharing portion of the program?
So when you're at a big hospital, everything's looked at by the legal department. But this is from CCJR. I mean, this BCPI came straight from the federal government. The rules were made by the federal government. So it's okay to gain share. Physicians can be incentivized financially for giving higher quality, higher value care. There's no issue with that. There's no issue with that at all. I mean, you can't say, I'm not going to do a certain implant on a Medicare patient. That's not what you can, and we would never do that. But we could say if the patient's, a certain activity level, they're not going to get a certain expensive implant. And that's well within ethical and legal means. So of course, everything a hospital does, the legal team looks at it. But these programs have been vetted by the federal government. So that's pretty good legalese right there. Next.
All right.
Question.
Thank you. Okay. How long was the project implementation? What are the timeframes with ROI, and was adoption a hard sell?
Again, adoption was not a hard sell. And let me talk a little bit about my institution. So we are a single specialty hospital that's, quote, academic, associated with the academic medical center. But 50% of our patients are physicians that do total joints. We have 30 guys that do total joints. 50% of them are not hospital employed. They're community-based guys. So we can't rule by fiat. We can't tell people what to do. But they all decided that they wanted to participate in this bundled care payment because of the possibility for enhanced reimbursement. So it was not that hard to get them aligned. So once you have them aligned, then it's about a 6-month process to ramp up get the pathways installed, get the IT done. It takes time, and it also takes the hand of an outside consultant or someone else outside the hospital to sort of share with you what other places have done, because you can't reinvent the wheel. A lot of this is done already. So if they could share with you other successful strategies, it makes it a lot easier. And ROI is within a year, because it takes a year to get reconciled.
All right. Sounds good. Another question for you, Dr. Bosco. Do you see TJR moving to the ambulatory setting? And if yes, how quickly do you think this transition will take place?
Well, we have a couple of guys who do the anterior approaches to the hip. And so far this year, we've done over 70 outpatient hip replacements. So, and the unis are almost all done. Unicondylar knee replacements are also all done outpatient. Knee replacements, I think it's going to be a little bit more because they're a little bit more painful. And certainly, the 70, 80-year-old patient is not going to be able to be done as an outpatient. This never happened. we're talking about these 75 patients we've done for hip replacements are all sort of healthier and younger. I mean, they don't have to be young at 65, but they tend to be in shape, and they're ASAs 1s or maybe 2s. So I do think more and more, especially total hips, are being transitioned to outpatient, but knee replacements is we're not quite there yet.
All right, sounds good. Maybe one more question we have time for. In order to discharge to the home, how coordinated is the therapy in the hospital? Do you have specific pathways and goals for each day in the hospital? And does this affect the LOS you mentioned, keeping the patients longer?
Yes, the answer to your question is yes. I mean, they have to be able to climb stairs, right? And again, the minute the patient is scheduled for surgery, the day they're scheduled for surgery, whether it's a month or 2 weeks before they have their surgery, our clinical care coordinators are on the phone with that family, that patient, letting them know their expectation is to go home after 2 or 3 days. So, and if they have any issues with going home, like accessibility issues, like stair issues, like they need toilet seats, all that stuff is taken care of before. The way we used to do it, and a lot of places still do it, is that the day they go home, they meet with the social worker, and the social worker has a laundry list of things they got to supply them. All that stuff is supplied before. All our patients get that stuff before they even have their surgery. So their fears are allayed, right? And again, if we have to keep them 1 or 2 extra days to prevent them from going to a rehab place, we'll do that, because we know the return on investment for that is very high. Because again, the costs of keeping a patient from post-op day number 3 to 5 is very low. The variable costs are very low. The only issue we have is if there's an opportunity cost for that hospital bed. But most places have excess capacity. It's not that big a deal. So, but there are pathways involved, because we don't want to send a patient home when they're not safe. We don't want to do that. But most patients can be safely sent home after 3 days.
All right, that will be our final question. I want to thank Dr. Bosco and Alicia for their excellent presentation, and to all of our audience for participating today. Our presenters will follow up on any questions they didn't have time to address during today's webinar. We will look forward to having you join us for future webinars. And this concludes today's program. Have a wonderful afternoon.